Hi, good afternoon and welcome to the afternoon breakout session titled Sepsis Update. I'm Dr. Leah R.G. and I'm the current president of the Virginia Pharmacists Association. The Virginia Pharmacists Association is proud to co-host this year's Patient Safety Summit in partnership with the Virginia Hospital and Healthcare Association, the Virginia Nurses Association, and the Medical Society of Virginia. It is now my pleasure to introduce our speaker for this session. Dr. Michael Hooper is the Vice President for Medical Affairs at Sentara Norfolk General Hospital. He is a specialist in pulmonary and critical care medicine, devotes his leadership abilities to helping Eastern Virginia Medical School, EVMS, and Sentara Healthcare make better use of the voluminous amount of clinical data available in electronic health records. He is a member of several groups focused on informatics and clinical decision support for Sentara Healthcare. He started with an informatics group at EVMS. It's improving the school's outpatient EHR to promote efficiency and patient safety. He is an assistant professor of internal medicine, chair of the Sentara Healthcare Order Set Oversight Group, and co-chair of the Sentara Healthcare Critical Care High Performance Team. We have time for one or two questions at the end of the presentation, so feel free to put your questions in the Q&A box. Please join me in welcoming Dr. Hooper for this presentation. Thank you.
Okay, well, thank you for having me. And Lena, it's saying I can share my screen as soon as you're done. Perfect. So let me get my screen shared. Okay, so wonderful. So again, thank you all for joining me for this breakout session. It's my pleasure to speak some about sepsis care and give some brief updates about what has changed with 2022. So first of all, I have no conflicts of interest to report. Just a brief background for myself. I was in medical school from 2000 to 2004, Vanderbilt University. Stayed there to practice internal medicine as a resident and then do my pulmonary and critical care fellowship up to 2010. I did a master's in science and clinical investigation, followed by moving to Norfolk, Virginia and becoming faculty at Eastern Virginia Medical School. I got my board certification in clinical informatics in 2015, worked at Norfolk General until 2019, at which time I became the Vice President of Medical Affairs and now the Chief Medical Officer at Norfolk General Hospital. So just to give you my perspective or background as I approach this subject. So for anyone watching this talk, you can go to www.minty.com and enter the code on this screen that's on top of every slide, or you can scan this QR code and that will allow you to give some feedback to questions throughout this. So you can use your phone or open up a separate web browser to do that. And I'll give everyone a couple of seconds to do that because there are a couple of feedback questions that will help you stay engaged throughout the presentation. It looks like a number of people are able to sign in and I can see that coming in now. So to start, just so I can get a sense for the audience out there, if you could take a second and fill out your role at your hospital, help me to get some sense of who I'm talking to and what my audience is. Fantastic. So can definitely see we've got a heavy administrative leader lean, which is not unexpected at this conference. There's some clinicians in the audience and quite a few people in other roles. Fantastic, still coming in. All right, appreciate it. I'll move on. So why is this important? Why do we talk about sepsis so much in healthcare when we're talking about hospitals and inpatient environments? I thought this one paper really demonstrated what many other quality improvement projects and papers have shown, which is that preventable deaths in patients in our hospital and our emergency room often trace back to sepsis, missed diagnoses, inappropriate or untimely management. And this paper found exactly the same thing. Roughly a third of the cases that they reviewed and deemed preventable traced back to cases where sepsis either failed to be recognized or was recognized very late in the course of the disease. And why is that preventable? Well, there's a lot of evidence out there, particularly in observational studies, that show that the later you recognize sepsis, the worse patients do. So on the left-hand side of your screen in that bar graph, you see two overlaid bar graphs. At the top, you see patients presenting with sepsis and the number of organ failures that they have at that point in time. And then you see below, if they presented in that state, what is their mortality rate corresponding to that? And you see what we often teach to residents or medical students, which is what I was taught as the 20% rule, which is for every one organ failure present at time of presentation, you add about 20% to that patient's mortality over the course of their stay. So very important to find people before they have organ failure or when they only have one or mild organ failure so that you can intervene and start to improve their chances at survival. On the right, you see an odds ratio of death in the y-axis, and on the x-axis, you see time from hypotension onset and sepsis to completion of administration of their first antibiotic. And that shows an exponential curve where delays in antibiotics lead to significantly higher increases to the risk of death. So we've got a disease where we need to find it, we need to find it early, and we need to intervene. It's common, it represents a significant portion of our opportunities for improvement in the hospital setting. So why do we have so much trouble? Well, one point I'd like to make is this idea of condition or disease, or some will use the term disorder. But the question to you, and you can answer this on your phone or in your web browser, is when you think about sepsis, is it a condition or is it a disease? We'll give everyone a second to fill that in. Right. So we see an overwhelming trend here, people going toward condition rather than a disease. And you know, why there's not a published answer on this, that is the common terminology used to describe sepsis. A disease is a distinct pathophysiologic pathway. So you have a problem, and for everyone with that diagnosis, they share a very distinct pathophysiologic problem and pathophysiologic mechanism, and that leads to very distinct and exact treatments for said disease. So if you have acute myocardial infarction, ST elevation myocardial infarction, you're going to have a thrombosis in a coronary artery nearly every time, and the treatment for that remains very focused on relieving that obstruction and on using medications that prevent that obstruction from getting worse or help to resolve it. But we don't necessarily have that in sepsis. Sepsis is more accurately described, I believe, as a condition. That's a more common or complex pathophysiologic pathway. And while there's shared principles, there's not exact overlay patient to patient and what that pathophysiologic mechanism is. When you look at sepsis, It is where there is an overlay between SIRS or some physiologic manifestation of an acute infection and an infection. That SIRS or physiologic manifestation can be mimicked by a lot of different things: trauma, burns, pancreatitis, surgery. And then within sepsis, that infection causing that SIRS type of response can be caused by a lot of different pathogens: bacteria, fungus, parasites, viruses. And what we've done in sepsis is take this heterogeneous group of diseases and try to classify them as a single condition that we can then study and come up with principles for treatment. There is some shared pathophysiology. So you have an infection that leads to some type of dysregulated immune reaction, although that dysregulation can vary dramatically. One pathway is this procoagulant microvascular thrombosis pathway that can lead to organ failure. You may also just have an out of control inflammatory cascade leading to direct damage to cells from reactive oxygen species. You may get vasodilatation, hypoperfusion. You may get capillary leak and damage from that. All of that leads to shared organ failure that is detrimental and carries significant prognostic implications for the patient. But the size of these arrows, and indeed whether or not these arrows are even present, may vary significantly from one infection to another, and may also vary by where that infection is occurring primarily in the body. Because we have a heterogeneous condition with a lot of different distinct pathophysiologic causes, we've had a lot of trouble coming up with targeted therapies to really apply to sepsis patients in general. What we see over and over again in the literature is promising phase 1 or animal data in very distinct types of conditions that do not bear fruit in phase 2 and phase 3 trials. So we have hundreds of phase 2 and phase 3 clinical trials in sepsis trialing specific agents that are directed toward certain parts of this pathophysiologic pathway that have not been effective. So we're left without any magic bullet for sepsis. Yet interestingly, we have seen two distinct trends over the last several decades in sepsis. Top row shows incidence of sepsis broken down by 3 different studies. So whether you look at a big US epidemiologic study, a French study, a Welsh study, you see the incidence of sepsis steadily increasing. And then at the same time, you see the mortality rate of sepsis steadily decreasing, even when you apply the same criteria for making that diagnosis. So the question then becomes, why? If you go back to the 70s and 80s at how did we treat sepsis at that point in time or severe infection, we had several established core treatments. We would try to obtain source control for the infection. We would give antibiotics to try to treat the underlying organism. We would resuscitate patients if they were hypotensive or needed to be better perfused. And we would provide supportive care, whether it be mechanical ventilation, dialysis, or whatever other ancillary treatments were needed to keep that patient alive. Over time, we saw the mortality rate come down. And so the question becomes, what have we been doing right? And how does that inform what we need to focus on and continue doing better in the future? So poll of the audience, if you can come up with single word or single phrase answers, what have we done over the last few decades? What has improved our sepsis care over time? So feel free to input that in your devices. Great. So you see a trend on the screen. You see early recognition, early detection, bundled care, complicated therapies, infection control, education, awareness, antibiotics, timeliness. So some of the things are universal, but shared in what we had already as established core treatments. So we have had things come to light over the course of time, things that carried great promise, where we had phase 2 or even phase 3 trials that showed promise. So Zygris, targeting CVP, glucose targets, vitamin C, immunonutrition, all things that promised to push things ahead, and all things which were refuted over time. We have had things that we do better to improve the care of sepsis patients, but when you look at it, it's really more of the same. You use better, more precise source control. We have interventional radiology now, more minimally invasive surgeries. We have other ways to establish source control that cause less harm to patients. We prioritize that and get that done quicker. Antibiotics are better. There's more choices. They're faster. Our resuscitation is faster and more precise. It's more guided by dynamic measures. We're able to look at cardiac function. We're able to provide better supportive care with better ventilatory strategies, better nutrition strategies, less harm to patients along the way. So that is where the trends in sepsis have been. And so the question comes for this talk, well, what's new in 22? Are there other things that have come along in the past several years that are worth discussing? Well, I think one thing worth discussing is that in the past couple of years, our Venn diagram for sepsis changed pretty dramatically. Instead of a big bubble for bacteremia that was causing that overlay of infection and SIRS, we had our hospitals filled with COVID patients. So these are patients that, unlike many sepsis patients, had one distinct pathogen causing their illness that had a very homogeneous presentation in terms of the pathways, biochemical pathways, or pathophysiologic mechanisms that were in play within their bodies. So this homogeneous population and huge number of patients allowed us to take a sepsis subset and do an amazing amount of research and treatment development over a very short time frame. So obviously a tragedy that this occurred, but it also allowed us to see that we could take a subset of sepsis, really study distinct inflammatory marker profiles where we could predict prognosis and predict disease. We saw significant hypercoagulability in this subset. We were able to measure that quantitatively in some scenarios and then potentially alter treatments. There was a clear benefit to steroids in this specific subset of sepsis. There was evidence in subpopulations that certain therapies directed at cytokine cascade manipulation led to improved outcomes. And there was a rapid maturation of clinical protocols to improve outcomes and a rapid production of multiple therapeutic agents that we'd not seen before in other sepsis subsets. That led many people in the professional community to start talking about, and this discussion indeed had been occurring before, but how can we start to better subclassify sepsis subsets and then come up with studies where we can really test some of these hundreds of therapies that were not effective in a heterogeneous population of patients and reapply them and or discover their value in specific subsets of patients. And so this work is underway. There are people publishing on ways that we can use microarrays or biomarkers to start to classify this better in the research world, and then come up with clinical applications for some of the many drugs that are on the shelf, which we currently do not know how to use. So those are not ready for prime time. They're not ready to be rolled out in 2022, but that discussion is happening quite frequently in the research segment and is something worth mentioning. The other thing I don't have a slide about, but that was something that is also being discussed a great deal as a result of changes during the pandemic, is just the idea of pragmatic research. And in real time, when therapies are unknown or there is clinical equipoise for therapies, how do we turn our hospitals ethically, morally, and legally into places that can generate data and quickly inform how to improve care in the future? The way that we do it now is we spend years designing phase 3 clinical trials that then take years to unfold, and then additional time to publish. And we learned that if we're rigorous about it, we can use the real world to do some of that experimentation if indeed there is clinical equipoise on certain therapies and certain interventions. And so that discussion is also underway and was fueled by the changes that we saw during the pandemic. The other thing that happened in the interim is we added a new set of guidelines come out from the Surviving Sepsis campaign, and those were released in 2021. So I thought in order to update, we should look at our primary set of guidelines and look at what has changed. So the actual document is 70 pages long and filled with a lot of dense text. But if you really take that, put it into categories, major categories, and then subcategories, the primary sets of recommendations really fall out like this. There's hospital-wide things that you need to do. You need to screen for patients. You need to have a performance improvement program. There's initial resuscitation standards, giving a fluid bolus to hypotensive patients on arrival, using dynamic fluid resuscitation techniques for monitoring the response to those fluids, using lactate as a global measure of resuscitation, targeting a mean arterial pressure of greater than 65 in the vast majority of patients. For general infection control, source control, fast antibiotics, appropriate antibiotics, multiple recommendations aimed at that, and considering the use of procalcitonin to DC antibiotics when they're no longer needed. For fluids, using crystalloids as a mainstay, considering albumin in only large volume resuscitations, but not as a standard resuscitative algorithm. Having vasopressors with norepi as a first line, invasive monitoring of BP in most shock patients, and starting peripheral pressors if no central line is available in order to reach that MAP goal as quickly as possible. In the respiratory arm, high flow over BiPAP, sorry for the BiPAP misspelling, using protocols to avoid excessive tidal volumes or plateau pressures, using a high PEEP, and using prone ventilation if the patient has ARDS. Other things that are mentioned are ECMO or VV ECMO for ARDS patients as a consideration if they're refractory to standard therapy. And then steroids is now more supported than previous in terms of an effective technique. Multiple other supportive care methods are detailed, but those include really what I would call just standard good critical care practices that are applicable not only in sepsis, but across a wide array of medical ICU diagnoses. If you look then and downsize those things where the evidence for them is low or very low in terms of the quality of that evidence, you then have what I have on the screen, and you can then focus on the things that are most likely to make a substantial clinical difference in your patient, at least based on the evidence. If you then focus on those things that are new or updated, there's actually very little in this newest set of guidelines. They mentioned ECMO, which had not previously been mentioned as a rescue technique in refractory respiratory failure, not responding to best practices for ventilatory management. They have a stronger statement around steroids as an intervention in patients with shock. And then they have more detailed recommendations around antibiotic timeliness for patients with shock or likely sepsis, recommending 1 hour as your timeline for antibiotic administration. And for patients with possible sepsis, where the diagnosis is less clear, giving some leeway to allow physicians and practitioners to work up patients in more detail before administering antibiotics, which can cause harm if overutilized. For ease of use, if you really further lump those recommendations into what we as hospital leaders need to do to improve the care of our sepsis patients, this is it in plain English. Find sepsis early, process improve within your hospital, resuscitate patients quickly with time-honored methods, control their source of infection, and use appropriate antibiotics quickly. No fancy fluids are needed. Crystalloid, preferably balanced crystalloid, is the treatment of choice. Other things like gelatins, hetastarches are clearly not recommended in the care of sepsis patients any longer. Your mean arterial blood pressure should be 65 or greater as a general rule in these patients, with only clinical exceptions and significant outliers. Evidence-based respiratory protocols are a must for every hospital setting, and those should include low tidal volume ventilation and controlling plateau pressures specifically. Steroids matter in shock patients and have really moved to becoming more of a standard treatment and are less debatable than what they were in previous guidelines. And then just good attention to detail, good critical care. There are hundreds of other things that are detailed with some specificity in the guidelines, but are not amenable to metrics or dashboards, but are simply things that you need teams aware of, checklisting when possible, and educating all of your staff members about those various things to make sure that they get accomplished. So how do we beat sepsis over time? I think when you look at a neighboring hospital that has figured this out, that is doing excellent 80% in their bundle compliance, delivering antibiotics in less than 45 minutes, I think what you need to remember is if you look closely, those were not overnight successes, but they took a long time, significant deliberate planning from a comprehensive team of experts in order to get the pieces right and move this ahead. And that's what we need to be doing with our sepsis teams at our hospitals to push our process measures, push our outcomes, and also make sure that we have the right teams in place to do all those other things that we can't measure that make the care in our hospitals better. So that is what I had for you today. I know that we went through that very quickly, but we had a hard stop at 40 minutes, and I wanted to leave a little bit of time for questions. So I've got the chat window open. Please input questions, and I will do my best to answer them.
Dr. Hooper, we asked if they would put their questions in the Q&A pod. I do have one question out there for you already.
Perfect.
Is there any consideration for prophylactic antifungal treatment in COVID patients, considering the incidence of fungemia?
Yeah, so I think the answer is, I don't believe that there's a role for prophylactic antifungal treatment in all COVID patients. I think that there is too much of a potential for harm than good to universally apply that. I think these newest guidelines are clear, and I think many experts have moved to the opinion that applying antifungal treatment prior to identification of a fungus is appropriate, depending on the risk profile of the patient that's in front of you. So am I going to use antifungal treatment in every IMC patient or mildly critically ill patient with COVID that has a fever and no other high-risk features or no other organ failures? No, I'm not. However, if I have a transplant patient who has been on antibiotics, who's got central venous access or wounds, and is at very high risk not only of acquiring a fungal infection, but also of doing very poorly once that fungal infection establishes itself, am I more likely to use antifungals at the first whiff of a problem in a patient like that? Absolutely. So I think empiric coverage for possible fungemia is something we should be doing in subpopulations of patients. But I think it's hard to write an algorithm to tell you when to do that.
Yeah. Next question, what strategies does your hospital utilize to manage time, like antibiotics given and lactic acid draws on time?
Yeah. So I think all hospitals do this differently. I think it comes down to a few key principles, though. One is you have to have some mechanism in your hospital that does not just rely on the practitioner thinking about sepsis to screen for sepsis. So you want to find a time zero for your patients, and you don't want to realize that late. So some kind of screening pathway to look for patients, and then some sort of escalation pathway for patients that have screened positive and have been determined on a subsequent evaluation after that screen to have a likelihood of sepsis. There needs to be a time zero, and then there needs to be some process in place to incentivize and help to manage delivery of care after that, specifically those early bundle elements that we know matter, like delivery of antibiotics. Yeah. The next question I see, which is your hospital performing at the 80% mark for sepsis, and what EMR do you use? The answer is my hospital is not performing at the 80% mark for sepsis, and my EMR is Epic. But going back to the first part of that question, I think that's something that we all want to strive for. And I think my approach, at least, has been to try to put the most weight and the most urgency on the elements of the bundle that I know have the highest likelihood of impacting the outcomes for that patient. So do I want the whole bundle to be compliant? I absolutely do. But starting out, I want to make sure that the elements of that bundle that carry the most weight for intervening on the outcome for that patient receive the most attention and are the most weighted. There are hospitals in Virginia that do very well at this, and I think that we should all be reaching out to those hospitals and trying to learn how they manage that and how they have process improved, particularly in their emergency rooms, where likely 70 to 80% of these cases are coming in.
Thank you, Dr. Hooper.
Yeah.
The time is up for our session, and we'll need to break out so that you can get to the last session of the day. Thanks.
Thank you.
All right, thank you, Dr. Hooper, for a great presentation. We will now end this session and provide our attendees a few minutes to transition to the next breakout session. Thank you all and have a great conference.
Thank you, Leah.